UCD for facilitating us once again for this operational brief, because it's a fabulous venue, and also we have a very close association with UCD. We have the NVRL and also a contact tracing centre here in UCD, and both have been extremely central in dealing with this COVID pandemic. So the purpose of today's brief, as we normally do, is to give an update on what's happened in the last week, the challenges we faced and how we've overcome those challenges, and also we will focus on three key areas: strategy, operations and clinical areas. So we'll introduce the panel as we normally do, and David, if I can start with you, please introduce yourself.
David Walsh, Director for Community Operations.
Colin Henry, Chief Clinical Officer.
Anne O'Connor, Chief Operations Officer.
And Paul Reid, CEO, HSE.
And I'm Paul Connors, National Director of Communications, HSE, and our two Irish Sign interpreters. We have Lisa and Vanessa, who you'll see in a little while. So the format for today, as usual, we have a number of speakers. Today we have three speakers, starting with Paul, who will give the strategic overview, followed by Anne, who will give the operational overview, and then Colin, who will give the clinical overview. And after that, then, we will get into the Q&A session. We hope to get this done and dusted in an hour. If we need to go further than that, we will. But RTE will be breaking its live transmission at 10:30 for Mass. Okay, so Paul, can I ask you to come up? Thank you.
Thank you, Paul, and good morning, everybody, again. As Paul has mentioned, I just want to touch on four key areas very briefly this morning to give you a weekly update on, firstly, some of the strategic measures that we're monitoring in terms of transmission of the disease, particularly the impact on our overall health system. Secondly, give you a brief update on testing and tracing performance measures. Thirdly, I want to talk briefly to update you on the process we're engaged in relation to going back to some of our non-COVID services. And finally, just to make a few brief comments in relation to, I guess, long-term residential care facilities overall, but in particular, nursing homes. And just in kicking off, to say that as of this morning, the number of patients with confirmed COVID-19 in ICU as of this morning is at number 48. Again, our thoughts with all of their families. With additional 12 suspected COVID cases also there as well, potentially. Overall, though, however, the numbers of people in ICU is down 70% on its peak from the 9th of April. It is also just important to point out, however, though, there are now a total of 270 people in our ICU. At the start of COVID-19, our total ICU capacity was 250 ICU beds, and we certainly did increase it during COVID, but it's just one that we have to monitor overall. Secondly, in relation to the number of vacant beds has fallen in our public hospital system, has fallen from well over 2,000 in April to just about over 800 this morning. And that does indeed demonstrate an increasing level of non-COVID services and the demand for non-COVID services now coming back on our acute hospital system. So we're now seeing increasing levels of occupancy both in our total ICU and general hospital beds, and it's something that we will need to monitor very carefully in the coming weeks as we continuously cope with COVID, but also revert and restore some of the non-COVID services. It does also reflect that we have gone beyond in the public system our WHO guidance and what you would be aiming to strive to achieve 80% occupancy level overall. Secondly, just in terms of testing and tracing, we've now completed well over 325,000 tests, probably closer to 330,000 as of this morning. As I mentioned last week, the positivity rate for those tests completed over last week and up to including yesterday is at about 2%. The highest positivity rate based on the NVRL tests has been among those close contacts of confirmed cases. And in light of that, just last week we introduced the proactive testing of close contacts, both asymptomatic and symptomatic close contacts. And to date, there's been 320 close contacts who have been completed this test under this new process. I just want to reflect briefly on that. Of those 320 contacts, 12% of those tested positive. And if you look at those 12%, and I know we're dealing with smaller numbers just over the last week or so, but just give you an insight into it, of those ones that did test positive, 73% of the close contacts were asymptomatic when they were tested. But they did give a positivity rate of 9%. And then the remaining 27% of those close contacts that were symptomatic, when they were tested, this symptomatic group gave a positivity rate of 17.5%. And this indeed provides a very early indication of the value of our whole raison d'etre of contact testing and tracing. And therefore, I strongly urge members of the public, as they are identified as close contacts, and we do offer appointments to come forward for testing, that they would take up that testing. It's really important for us, and it's a really important and major part of the process to continuously to track the disease in the community and our continuous drive to indeed to eliminate it. So we're putting a massive investment in this testing and tracing, and I really do urge the public to come forward in this. We're one of the few countries who are actively involved in proactive management of close contacts. Staying with testing and tracing, our turnaround times, just briefly, 80% of all appointments for testing are now on the same day or next day, generally depending on a person's availability. We took over 27,750 tests this week, still less than our capacity, and we're continuously meeting all demand. About just over 13,000 of those, 13,250, were taken in community and 14,000 in hospitals. On our turnaround times, obviously with our positivity rate, 98% of those who will have been tested will have tested negative, and these will most likely have received their test in 2 days or less. Indeed, as you see, a significant proportion of last week tested in hospitals, they will have received their negative test results, most likely in less than a day. So significant improvements also being made in our total turnaround days. In the last 7 days, we've delivered a median, which is the end-to-end turnaround time of 2.3 days. And just to state that again, that end-to-end is from the point of referral all the way through to the testing or contacts of the positive case. So all the way through to completion of result and contact tracing. Indeed, the swab to lab result, which is another measure we measured, the average over the last 7 days has been 1.3 days. And finally, 83% of the tests are now being turned around within 3 days, end to end. Just on the reporting of that, we do have a daily dashboard which we're currently finalising and regularly updating, and the dashboard will have information daily around most of what I just outlined, with the exception of the end-to-end, which we're going to report on a weekly basis, and that's purely on the basis of quality assurance of the data from the labs, because they currently don't timestamp the test results, and that's something we're moving towards. So for now, that'll be weekly. The rest will be published daily. Just want to turn briefly to long-term residential facilities overall in relation to testing. We have now completed over 101,000 tests at these residential settings in 1,239 locations, 99% completed, a small number of locations to be completed overall. We're continuously implementing a number of process improvements as part of our testing and tracing, largely around our public health and how our public health, because obviously we're managing the more complex cases now, because there's less in the community, and largely process around how they manage it on a consistent basis all across the country. And indeed, continuously addressing data quality issues and what more we can automate as part of the process. Just briefly on the GP test results support service, I mentioned we had put this in place since the 14th of May, a process where GPs, if they become concerned around a result or a result not emanating quickly, support line to help them that. To date, we've received 446 queries received from the 14th of May to the 25th of May, and 80% of these have been resolved in 24 hours. Thirdly, just want to briefly update on our process that we have in place currently in relation to non-COVID services and how we restore major elements of our non-COVID services. And just to say, this is not a big point in time, because already we have started to restore a significant level of non-COVID services. Our hospitals and our community and our social care services are getting busier already. But I had commissioned a framework which is being completed by the Chief Clinical Officer and the Chief Operations Officer to be developed and worked on over the next week. We will finalise that over the next week. But there are a few key principles that I wanted to set out for you about how we develop that framework. Firstly, it is on the basis that we continuously monitor the capacity overall in our health services, because we do have to work through this on the basis of the disease is very live, it's still with us, and we have to protect against any further surge. Secondly, it will be phased and it will be clinically prioritised and guided by the public health measures that we monitor along. Thirdly, it will utilise available resources and expertise, and also developing new ways of working, some of which we have put in place during COVID. And finally, we will restore those, building on international knowledge that's being gained from other countries and other health systems as they've restored other services in a COVID environment. The key elements of the framework will look at our acute hospital systems, our community services, our social care services, our national cancer services, our national screening services. And there'll also be a key element of this, which is about how do we enable those services. What is the infrastructure we have to put in place? What's the property issues that we have to address and the IT architecture to support it? But just to briefly say a bit of clarity on what the framework is or isn't, this certainly isn't a big major point or publication that we plan. It's an iterative process, some of which has started already, some of which will evolve as we progress over the coming weeks and months. But it does set out national clinical priorities at national level that we want to implement locally. And also, it's not just a tweak of the services, because living with this virus, we have to be very careful about how we restore those services and in what manner we restore them. And some of them will be less efficient than currently the way we do them, just by the very nature of how we protect the public. But in other ways, we will, as I mentioned, build on some of the new ways of working that we've put in place. Finally, just wanted to briefly touch on nursing homes in particular. I just want to say, firstly, the HSE strongly welcomes the review group established by the Minister, and we will hugely embrace the workings of that group and contribute as significantly as we can and as openly as we can. We are indeed hugely open to learnings. Just like to say that there's been much commentary of late about who knew what and when, and what letters were sent by who and to when, and who received them and what did they do with them. I just want to make a few brief points overall. First of all, from my perspective, three quick points. Firstly, to state that this is obviously a very tragic and has been a very tragic time for families who've lost loved ones in nursing home settings and indeed long-term residential facilities through this awful virus and disease. And indeed our hearts do go out to them, and also out to the residents of these locations, and indeed also out to staff in these locations who continuously provided tremendous care and have a tremendous attachment to their residents. And I want to thank all of them in all of those settings, public and private. Secondly, just to mention that our actions in the HSE over the last few weeks, as we've been dealing with these viruses overall in public and indeed private nursing homes, they haven't been driven by any letters, they haven't been driven by correspondence, they've been driven by the absolute commitment of our teams across a wide range of services, whether it's infection disease control, whether it's our acute geriatricians who provided support, whether it's our community teams, our national ambulance services who provided support, our distribution of PPE. That's all being driven by the strong commitment of our teams in the HSE and the desire to do the right thing at the right time throughout. And it hasn't been driven by, we haven't been managing this pandemic through correspondence. We've been managing it well before we received correspondence and well after we received correspondence. And I just want to make that point simply to recognise the wide range of fantastic supports that our teams have been providing. Third point I would just equally make briefly is my own reflections are that there are obvious gaps in clarity of responsibilities in the overall governance and oversight of private nursing homes in particular. We would work with all of the key stakeholders. We've had great workings with HICWA and Private Nursing Homes Ireland. But I think any reflection at this point in time can say it is something to be looked at. It is a consideration obviously for policymakers and not for ourselves and the HSE. But it would seem like an obvious learning to date. And just to say, the residents of these locations are generally frail, obviously elderly, and indeed vulnerable. And I will continuously ensure that the HSE are wide open to any learnings that emerge over the coming while, because we're still very much living with this virus. So finally, closing messages from myself. Firstly, we continue to make good progress on the overall strategic measures around COVID, but we must remain conscious that we are getting close to our maximum occupancy levels overall in our public health acute system. Secondly, we do, as we identify close contacts of positive cases, it's really essential that the public come forward for their tests as we offer tests to them. This is a major driver, this is the absolute driver of testing and tracing, to follow the disease, follow through where it transmits and eliminate it. Thirdly, we continue to work on a framework for non-COVID services, and we expect to have that worked through over the coming week. And it will be adjusted as we progress over the coming weeks and months. And finally, in terms of nursing homes and long-term care facilities in general, HSE, as I mentioned, are wide open to any lessons that can help inform us for the future, protection of a very vulnerable group in society. In the meantime, we'll continue with our wide range of supports that we provide. Thank you. I'm going to pass across to my colleague, Anne O'Connor.
Good morning, everyone. I'm going to talk through the operational update in terms of activity across our sites, both in terms of the regular attendances and then some COVID-specific work that we're doing. So in terms of attendances over the past week, these are continuing to increase. Attendances at our emergency departments have gone up by 5% in the week to 21,367. Now that's still over 17% lower than the same time last year, but increasing week on week. Our ED admissions also went up by 2.2% to 5,847, and again that is now under 10% less than last week, or than last year, sorry. So we are seeing more people attending, more people being admitted, and particularly in relation to our over 75s, as I stressed on Sunday, we have seen another increase of 3.4%. So again, more people aged over 75 attending, so 2,969 in the week, with just a 0.6% increase in the admissions for over 75s to 1,559. So we are still below the same rate at this time last year, so 8.3% in terms of the attendances of over 75s and 9.3% in terms of admissions. But as Paul referenced, we are seeing more people attending, we are seeing more people being admitted, and our sites are becoming busier. We're managing to maintain our patient experience times at the last, I suppose, much higher than last year. So our 24-hour PET time is nearly 100%, and our 9-hour patient experience time for over 75s is still over 80%, so nearly 82%. That is significantly higher. So even though we are seeing higher numbers of people presenting aged over 75, our patient experience time is much higher than it would have been this time last year, where it was only about 50%. Trolleys continue to be around the 46 mark. I think there were 48 before that, so we're not seeing a huge increase in trolleys. And as I mentioned previously, we do use our emergency departments in some locations for our COVID pathways because we can isolate people. It's not necessarily a reflection of trolleys as we might see in the wintertime. Sometimes it is just the environment that is better suited to COVID. Our delayed transfers of care continue to be over 400, so these are the people who could be discharged to other facilities, impacted in the main by the fact that we haven't been discharging to nursing homes as readily as we would previously have done. We are seeing some nursing homes now being declared free of outbreaks, and we are in a position where we can start discharging in some locations. So there's work going on locally in respect of that. And there are particular rule sets from public health in terms of how we can discharge to those locations. Paul referenced the occupancy in hospitals, so 233 confirmed cases in hospitals with 223 suspected cases, 48 in our ICUs with 12 suspected cases, and that's out of a total of 270 people in ICUs. 817 beds available overall, which is coming down considerably, and 116 still in ICU. So our ICU capacity has remained okay, but we are seeing our general beds filling up more. Private hospitals, we now have 291 consultants who are signed up for the private hospitals. The inpatient occupancy rate there is now 51%, with our day case productivity in the last week up at 149%. So we are using the beds more than once in a day in the private hospitals for day procedures. In terms then of, I won't mention testing, but in terms of our assessment hubs, we have got, again, still a relatively low rate of referral to those. So to date, we've had 3,036 referrals with 2,566 people attending appointments in the clinical assessment hub. So they are part of the consideration in terms of the work that Paul referenced there around service continuity and how we can look at all of the capacity that we have available to us as we get back to a level of service provision. In terms then of self-isolation, we continue to receive referrals for City West, 603, and we've so far admitted 517 people to City West for self-isolation. Just to touch then on the supports to long-term residential care, we continue to increase the number of locations that we are providing support to. As of yesterday, we're providing support to 852 locations in total. As I mentioned on Sunday, we've introduced a category for these locations that is the white category, where these are facilities that are just on a regular supply route now for PPE and pre-COVID support, so nothing COVID specific other than the provision of PPE. So out of the 852, we have 592 facilities in that category that are not receiving any other supports. We have 7 facilities that we have most concerns about. They are both public and private facilities, and they would be facilities where we would consider there to still be a significant risk in terms of the operation of the facilities and where we are deploying significant resources. We've 64 other facilities that are, in receipt of supports, and 189 that we consider to be stable. We still are keeping an eye on them, rather than saying that they're in the white category. So out of the 852, we're moving to a point where there is a much smaller number that are receiving intensive support from us. The breakdown of that would be 430 in older persons facilities, 252 for disabilities, 88 for mental health and 82 others. So as we have rolled out testing across mental health and disability settings, we are identifying facilities that are getting more support. Just then, in terms of the deployment of staff, we still have 403 staff deployed across 90 facilities to residential care. 62 of those facilities relate to older people, so we are also deploying staff to some disability and some mental health settings. Just then to move on to the accommodation, we have seen, to move on to PPP first. In the past week, we have delivered over 10 million pieces of PPE, so nearly 11 million actually, in terms of the items. Now the breakdown of that continues to be highest to residential care, so almost 37% of all of our PPE is going to residential care settings, with nearly 24% going to home care. So the bulk of our PPE delivery now relates to residential care and home support. Acute hospitals are getting 20% of it. We're delivering just yesterday, as an example, across 426 sites, and we will be delivering in a day about 2.5 million items of PPE. So it is still a very significant work stream, both in terms of the procurement of it and critically the deployment and the logistics around deploying PPE across a much higher number of locations than we ever would have done previously. Just then, in terms of staff accommodation, I gave the update on Sunday, so we continue to see a relatively stable number of people seeking accommodation, just under 1,500. And maybe just to focus on something, so before I finish, we talk a lot about older persons and the work that we're doing in relation to residential care, home support, etc. But maybe just to mention some of the collaborative working that has been going on with Alone in respect of reaching out to service users to support them in their own homes. We've been doing a lot of work with Section 38 and Section 39 agencies to support people who are vulnerable in our communities. And we referenced many weeks ago now the concern that we had around people just not being as visible, not being able to attend appointments as easily or have family visit as easily. So organisations who are reaching out to people in their homes are critical at this time. Alone is a merger of 5 different organisations who support and empower older people and support them to remain at home. But just as an example of the type of activity that's going on, between the 9th of March and the 24th of May, they have received over 21,000 calls to their helpline and have been delivering 2,500 practical supports. Critically for us, they're actually making calls, so nearly 80,000 calls to people. And again, that's a level of support and outreach that is crucial and hugely supports people in terms of just maintaining their well-being or where they have concerns or feel vulnerable at home. Alone have also worked with us in terms of continuing to provide ongoing supports to over 11,000 people and critically identifying over 600 vulnerable people that we have worked collaboratively with in terms of supporting them. So I think, we focus a lot on the work that goes on in hospitals and in residential care settings, but it's really important to acknowledge the work. And I just want to thank all of the voluntary providers who have worked with us during this time to help to support people to remain at home and critically to provide very practical supports to people in terms of meals and other practical help. So I'll finish on that and hand over now to Colm. Thank you.
Thank you. I'll be brief. It's now almost 3 months since we had our first case in Ireland of COVID-19, and we've learned so much, not just in Ireland but across the world, about this virus, this new virus, in terms of its impact on humans. We've learned about the mode of transmission, we've learned about its behaviour, and we've learned how we can break the chain of transmission. And this learning is continuing and gathering pace at an unprecedented scale right across the world. However, much remains uncertain. In terms of treatment, the early promise of some drugs, such as hydroxychloroquine, has now disappointed. Other drugs, remdesivir, have shown modest gains in certain settings. And it's regarding vaccines, despite again unprecedented collaboration internationally, it's not yet clear if we're going to come up with an effective vaccine. In terms of immunity, it's of some reassurance that we know that antibody testing is taken with the right test at the right time. People will demonstrate antibodies to COVID-19. What is not clear yet is the duration of this immunity, and that will play in very much to the notion or the feasibility of vaccine development. And sadly, as we've heard, there have been over 1,600 deaths, many of them in residential care facilities. However, the feared surge we had when we had that first case 3 months ago, which seems like decades ago now, didn't materialise to the degree we worried about at the time. On April the 16th, we had 864 cases in acute hospitals. Now we've 233. On the same date, April the 16th, we had 144 cases in ITU, with every expectation it was going to surge further. At that time, again, it's easy for us to forget, we were looking at doubling times of 3 or 5 days. People in the hospitals of new cases and of ITU admissions. But now we have 48 cases in ITU. And difficult as that may be for those patients and their families, as a society, it's a reassurance to us that it didn't surge to the levels that we feared at that time. We've also seen the testing go down from a peak of 25% positivity, albeit in a lower scale of testing, to now falling week on week to now at about 2%. So all the signs are, as a virus, in terms of its community transmission, is that it's under control. And this has happened because of the phenomenal effort of all of us in this country, following those difficult measures that were brought in that involved difficult constraints on how we interact with each other, particularly for older people. But people's adherence to those measures have led to these significant gains, and those fairly apocalyptic predictions we had only a few months ago not materialising. So coming into a bank holiday weekend, I'm sure we'd all urge each other to continue this good work and to not ease up and not reverse the gains we've made and which were hard fought for over the past couple of months.
Okay. Thanks, Paul, Anne and Colm. We'll move into the Q&A session now. And as usual, I know who you all are. If you can please raise your hands. We have a roving microphone. And introduce yourself and the organisation you're asking the question on behalf of, please. So, Sinead, you have your hand up there, so we'll start with you.
Sinead Crowley from RTE. Can I just go back to what you were saying about the people who are contact tracing? Can you just give me those figures again? And are you worried that people who are being contacted aren't actually coming forward for testing?
Yeah, so from just last week, we started the process of proactively, we're obviously following through the contacts, but now we're actually following through to offer them an appointment for a swab test. That process, we're one of the few countries who've started that. And it's very early days, but the numbers I just mentioned, about 320 people have been contacted and offered a swab test. So that numbers are going through. I'm just making the point that it's really important, as we offer the appointment to people, that they do come forward and take it up and take up the test when they're identified as a contact. What we've seen is positive numbers coming through both in terms of symptomatic and asymptomatic cases. So even being asymptomatic, you might think, I haven't got the virus, even though I'm a contact, but we're seeing a significant percentage do have the virus, both symptomatic and asymptomatic. So it's really important that people come forward, have the test. That's our way of tracking the virus and following it and continuously suppressing it in the community.
That's it, Sinead.
Actually, just one other question, please. In terms of then, you have capacity, obviously, for testing, and you've said that. Is there any plans to test other groups of people? I'm thinking, for example, schools or children. There's talk this morning of maybe summer camps coming back. We've heard about footballers being tested. Is there any talk of maybe testing, say, a group of children who haven't been in contact at all, but so they can progress to a new stage?
Yeah, I'll let Dr. Colman just answer that, but very briefly, we are looking at a new testing strategy that will work through an effort just about what are the areas that we proactively test. Obviously, what we have seen, though, just to make the point, when we proactively tested the likes of nursing homes and long-term care facilities, overall it was a 3% positivity rate. So we do have to be careful about where we get the best use of resources in testing. But Colin, do you want to just take
Yes, just to address briefly, it's important that we appreciate the limits of testing. It's a point-in-time exercise that tells you something about that individual or a group of people at that particular time. It doesn't tell you anything about the following day. So it can, in that context, if people lean too much into it, provide false assurance and distract from more important control measures, which are those measures we've heard about. I won't repeat them, but you're familiar with those hygiene measures, those distancing measures, which act to break the chain of transmission of the virus. What testing does is enable those control measures, but it isn't a control measure in itself.
Okay, Conal.
Yeah, just to follow up on the contact tracing, Paula, if that's all right. Can I just touch on something that you mentioned there last week, that I think your aim was that 90% the turnaround would be within 3 days, is that right? It's about 83% at the moment, is that right?
That's right.
And can you just explain perhaps why you haven't got to the 90% yet? And also, can you just touch a little bit on the dashboard you mentioned as well? I think you said you'd have some results publicly available, but you wouldn't have the turnaround, the swab to test result perhaps available.
Yeah, so just on the first one first, we had a couple of measures. First of all, we had swab test to result, which was 2 days, and we're at about 1.3 on the average on that. The second result was the end-to-end referral to contact tracing, which was 90% to be completed in 3 days, and as of the first week, we're at about 83%. That will improve. First of all, 2 issues just to say to that. We are obviously dealing with more complex cases now than we would have been routinely dealing with in the past. So they are cases that have to be followed up, particularly long-term care facilities, and they can take longer, or mental health areas, or indeed homeless places, etc. So they are more complex cases, which will take longer. That's where we currently are in each measure.
And just on the data itself?
Apologies. On the second one, on the data, our dashboard will have all of the measures, including the swab test to result, including the volumes tested each day, rolling over the week, including the mean average of contacts per person. The one which will be produced weekly is the end-to-end piece, and that's largely because our labs currently don't have facility to timestamp the lab result. We're working towards that. It's going to take us a bit more time. Yeah, the dashboard will be available from this evening. There's some up already. There will be extra on it now, but that last one will be published on a rolling weekly basis.
Okay, Nicole.
Nicole Gernon from Virgin Media News. Just a question in relation to, a couple of questions in relation to care home deaths. Obviously, the latest figures show that we have one of the highest deaths in the world. And HICWA during the week in the Oireachtas committee said that at the start of this pandemic, they didn't think that the HSE really knew the care home sector. I was just wondering, could you just respond to, I suppose, the care home death rate at the moment, and also the what HICWA said during the week?
Okay, Colin.
Yes, I've seen the data that informs that what you just said there. It doesn't say we have the highest proportion of deaths in the world. And I'm not taking away from the tragedy of those deaths to family and friends of each of those loved ones. What it shows is, as a proportion of deaths reported in Ireland, residential care facilities and in general nursing homes are second to Canada. But what it also shows, if you read the small print in that report, is that of the countries measured, where measurements took place, 20, there are different ways of identifying and measuring deaths. In some places, it was all lab-reported deaths. In other countries, it was suspect deaths. In other countries, they added in as well excess deaths. Now, in this country, what we've done is we have identified in residential care facilities not just lab-confirmed deaths. We've also given license from an early stage to identify probable or suspect deaths, and the number of deaths we report each day, as you heard those evening teleconferences, includes that whole figure. Now, an exercise was carried out by NEFIT where they did a survey of nursing homes some weeks ago, and they looked for excess deaths over a set period. And those excess deaths that were reported conformed to the number of deaths in terms of confirmed deaths or suspect or probable deaths that have come through from COVID-19, which shows that that in this country at least, whatever else we have to learn, we have been actively seeking out and allowing practitioners to record not just lab-confirmed deaths, but any probable or suspect deaths. And that hasn't happened in other countries. And you know, I'm sure if you're reading from your colleagues reporting across the water, that there's a fear that there's substantial amounts of unreported deaths in that setting. Now, what's important for us to realise is not just that those countries measure differently, but it also, if you compare countries, you have to measure like with like. So if you, it's not just a question of proportion of deaths that took place in nursing homes. What is the whole proportion of deaths in any population in any country? And NEFIT has carried out an exercise, which I think they'll be discussing later in their press conference this evening, looking at the rates per population of deaths. So when you correct that data for the population in Ireland and the deaths per head of population, and you correct it for density of population, you'll find, as will be discussed later at the Department of Health conference, that we are among the lower and lowest rates per population in Europe. So while in the strict sense of the word, it does show we have a higher proportion of deaths that took place in residential care facilities, that doesn't take account for what our overall rate of deaths are per population.
And to be clear, that was a study of 16 countries only, not the entire world.
Then just the other question in relation to the HICWA, what HICWA said in the Oireachtas report, and I just wanted to ask as well in terms of testing in care facilities. So we knew from a couple of weeks ago that the testing had been completed in nursing homes. Where are we with the testing in the other care facilities? And then also in terms of retesting, there has been suggestion that we should go back and start, retesting in nursing homes as we go along. Is that something that's on the horizon, and where are we in that?
Just on the testing, the long-term residential facilities are practically complete. It's 99% complete. There's about 3 locations out of 1,250 to be completed. So 1,249 are completed. There's about 3 or 4 more left to complete it. And that was 101,000 people between residents and staff all across those locations. In terms of repeat tests are in plan, I think I'll just refer what Dr. Colin Henry said a minute ago. I think it's important to again state a test is a point in time, and you don't know what might happen the next day or the following day, whatever. And separately, the whole public health testing strategy is a discussion that's still ongoing with NEFIT, and will be guided by whatever recommendations emerge from that policy.
Okay, Casey.
Casey Reardon from News Talk. Have you quantified how many cancer diagnoses will potentially be delayed as a result of screening being suspended for so long?
Colin?
We haven't yet quantified. Clearly, we have an idea of the performance of our screening programmes, and we know that as was directed correctly in view of the risk to patients and the healthcare settings, that all non-essential services will be paused on March the 27th. We know that from that date onwards, we haven't been carrying out screening the way we were. And that's happened right across the world. So it's a challenge not just for us, but for other countries, that screening programmes have been paused. They have undeniable benefits, and we're very proud of our own screening programmes in this country and the gains they've made. The oldest one being the breast screening programme, which was established in 2000 under the leadership of Dr. Anne O'Doherty. What I would say is that what we know about screening and about other services, it was very easy to switch it off. What's much more difficult is to switch it back on again. Because the idea of screening, which is a population-based programme, we bring large volumes of people in for a test, and a small proportion of those patients then go on for further tests, examination, and even surgery. That in an environment where distancing is required, where stringent infection prevention and control measures must be adhered to, means that we have to relook at the whole model of screening, and in terms of large volumes of people being brought in a congregated way to a healthcare setting. So we are working with our 3 cancer screening programs and the other screening program, diabetic retinopathy, to see how we can resume screening programs in a COVID era, which protects patients and ensures there are no outbreaks in healthcare settings as a result of people congregating.
Sorry, just to follow up, you mightn't have quantified it, but you surely would know how many people or how many cancers are caught on a monthly basis in normal scenarios. And based on that number and the fact that we're kind of in decline in terms of the virus, is it not now more dangerous to not have screening than to have screening? And should it not be kind of ramped up as a matter of urgency?
Without doubt, we'd like to have a screening. We wouldn't have wanted to stop our screening program. As I said, they're all benchmarked internationally. We're very proud of them. But the fact is, to illustrate for you, the waiting room, even in the Marion unit, for example, the waiting room has room for 45, 50 people. Now we can only 5 or 6 people can wait there. The van for mammography usually deals with 40 to 50 people per day. That won't be the same now. The very exercise of mammography, which is a very close contact between a radiographer and a patient, has to be revisited in terms of the throughput, the volume and the pace. And then you have to think of the services on which screening relies, which are further diagnostic services, surgery, and the changes that are required in these services in the COVID environment, which demand, again, distancing, demand infection prevention control measures, demand a slowing of the pace and flow through these services. But our priority at the moment in terms of cancers, is the question you ask, is our rapid access clinics have remained. There's a drop-off in referral to them and people presenting, and our priority at the moment is to get them back up to the levels of activity they were, to ensure people who have symptomatic disease, be they breast, colon or otherwise, are aware of their symptoms, present early to general practitioners, and are referred at the earliest opportunity to these services. And our breast screening program, for example, is now supporting symptomatic breast disease as a priority. That's where our priority is at this point in time.
Okay, Liz, and then Jack.
Hi, Liz Farsacci from the Irish Mirror. Thanks again for the update. I suppose one follow-up question, do we have a time frame about when we can resume screening services? And then secondly, I think you said, Paul, that the majority of cases are actually asymptomatic, and I suppose what does that mean? Is that true? And then what does it mean for perhaps this bank holiday, as we have to continue with social distancing and everyone being aware that they might not have symptoms? And then finally, Dr. Henry, you mentioned still lack of treatment, or we're a long way from treatment or vaccine. Could you maybe talk a bit more about that?
Okay, screening first.
The first question, screening in short, I can't give you a date for resumption. What I can say is that our screening programs, we had another meeting with all screening programs last night. They're linking with their colleagues internationally right across the world to see how, in an environment where there's no evidence, and we're relying on the principles of infection prevention control for what is a very transmissible virus. So we have nothing to draw upon here, apart from what other countries are trying to do. And like ourselves, other countries want to restart their screening services too. And there's different plans looking at volume, the type of screening test, focusing on high priority groups. So if you ask me, is there a date for starting up the program the way it was before COVID ever came, I can't say that. What I can say is we have to re-look at the priority groups. We have to look at the screening test, and we have to draw on international experience. Second question, if I could, on that issue about the asymptomatic.
Do you want to touch on it firstly, or?
Yeah, just what I would say with the asymptomatic is and Paul touched on this point, and it is important. It's all the more reason why he and we are encouraging people to present for testing. Is some of these people are actually pre-symptomatic. It's just they haven't developed their symptoms yet. So, and we know that, again, we began to learn about pre-symptomatic transmission as we learn more about the virus. We know that people who become ill can shed the virus for 48 hours before. We learned from a study in Holland back, I think, in April, that healthcare workers who subsequently became ill continued to work in those early stages of symptoms. So some of those people who we think are asymptomatic are actually, will develop the disease later, become ill and shed the virus. And that's why it's so important.
Then the vaccine?
The vaccine. There's huge work done on it. I'm sure you're all seeing that yourselves from reports from your colleagues internationally. Just bear in mind that when HIV came out, there was huge investment and the collective intelligence of the scientific community put into developing a vaccine. It didn't materialise. Fortunately, a treatment materialised. So there is no guarantee that an effective vaccine, which fulfills all those criteria of being effective, of conferring immunity, of being safe, and of being manufactured on a mass scale for a population, there's no guarantee that that will happen.
Okay, Jack.
Jack Corgan-Jones from the Irish Times. Paul, you said there are obvious gaps in clarity and responsibility in the overall governance model for nursing homes. Can I get you to elaborate on that? What are those obvious gaps? What needs to be done?
Yeah, from my perspective, and I said this before, just if you look at the wide range of supports that we put in place over the last 3 months in particular, we did that because it was the right thing to do. We're living in a pandemic, whether that was providing PPE, whether it's providing direct resource, multidisciplinary teams. That's what we do during a pandemic. It's not normally what the HSE does on a year-to-year basis. We don't normally have direct relationships with private nursing homes in particular. And that's purely what I'm saying in terms of that. So whatever the model is for the future, you've heard HIQA express some concerns related to it. From my perspective, the HSE don't have direct relationships with private nursing homes on a year-to-year basis, but we provide the right supports as required, and particularly in a pandemic. And I just believe that's something that, you know, has obviously emerged in the last while, that it is a consideration. And I've no doubt the expert review panel that'll be something they'll engage on.
Just bring David in on that as well, Jack. Because
yeah, and I might just clarify one of the earlier comments in relation to the HSE not having a knowledge of the private nursing homes, and coming from the Chief Inspector from HIQA. And if you look prior to HIQA been established, the HSE and before that the health boards had a role in the regulation of private nursing homes and would have had a much more intimate knowledge of what they were doing and their capacity. Obviously, HIQA now operate to a far more comprehensive set of regulations, but that relationship moved from being one between the health service at the time and the private nursing homes to one between the regulator and the private nursing homes. So as part of the processes over the last 3 months, I mean, on a daily basis, the Chief Inspector gives the HSE an updated list of nursing homes of concern, and that forms part of our intelligence then around making sure that local COVID response teams and crisis management teams are directing their resources to the right locations. And it's been one of the very positive pieces of the relationship with HIQA. So then, just to follow up on what the CEO has said, as part of our crisis response, we've stood up 23 COVID response teams that are providing an enhanced level of support and wraparound around all long-term care. And I think, you know, where our thinking is currently at is that combined with an enhanced outreach role from acute hospitals must form the basis going forward as to how we provide that wraparound around the totality of long-term care.
Jack, back to you. Yeah.
Does that amount to a closer oversight of private nursing homes by the HSE? Is that a fair characterisation? Going forward, that's kind of what you want, is it?
Well, I think oversight is the wrong word, because private nursing homes, no more than our own long-term care, is regulated by HIQA. But this isn't so much about the homes, but around the residents in those homes and having the correct clinical pathways to and from the various other aspects of service.
And do you want to come in there?
Just to add to that, you know, our model for the future, which would be in line with, you know, Sláinte care and all that, is around having community health networks. So in a given area, we will have a network of supports available to whoever lives there. And I think from our perspective, that will have to include people who live in nursing homes in some way that is more enhanced than what it has been heretofore. But there will be a mechanism there for us to put our hands around local populations in more detail over the coming, I suppose, months.
Thanks. Just on something else you mentioned, and you said, I think, that there's 400 people kind of who normally, under normal circumstances, under peacetime circumstances, would have been discharged, and they're still in the acute hospital system because they haven't been, there's no place for them to go effectively, or because normally they go to nursing homes, they can't go there. Is that having an impact at all in the acute hospital system? I know there's obviously a lot of capacity there, it's not as busy as it usually is, but has that had a knock-on effect at all?
Yeah, I think so we would always track our delayed transfers of care. So the highest, as an example of what that number would normally be, the highest we went to in the winter period, so seems like a long time ago now, but back in February we went up to about 670. We were just under the 700. The lowest we went as part of our response to COVID was down to 211. So we've kind of gone back up to the halfway mark really between the two. And for us, really, what that signals is, I suppose, a challenge around the flow. So one of the most important things in acute hospitals is the flow of people from the front row right through the services and discharged out the other end. It's not just in relation to long-term care, so it is also, we can have people delayed going home, awaiting home support, awaiting adaptations to homes, or awaiting some kind of very complex and intensive type of rehab that isn't readily available. So I think because we've had capacity, it hasn't had the same impact that it might have had it happened back in November or February. But there is no doubt but that as our beds fill up more, and as Paul referenced, our occupancy is key for us. So we have to manage that occupancy, and clearly having over 400 people who we're identifying as being appropriate for discharge means that we're using beds. And, you know, it's important. People, you know, still have, many of those people still have ongoing health needs. They don't necessarily need to be in an acute hospital, but they still need a level of support, which is why they can't just go home. So yes, it isn't really having an impact yet, but as the number of available beds go down, it will.
Okay, Keenan.
Keenan Brennan, the Irish Examiner. Can I just start with the 73% asymptomatic figure that was mentioned? I just want to dig into it slightly so I can get it straight. So that's 73% of close contacts. Is that correct?
No, just take it at top level. So we contacted 320 people who are contacts. Of that, 12% of those tested positive. Okay, and of that 12%, that number, when we asked them, 73% of them said they were asymptomatic, and 27% of them said they were symptomatic. So it was of the ones who tested positive. We further broke it down just to give us a better level of understanding. Which brings us back to our key message. As people may feel, if they're contacted, they may feel they're asymptomatic. It's really important they come forward for a test.
And just on that, you mentioned repeatedly that you want people to come forward, but these are people who have been contacted being offered a test. Is that right?
Yes, we're proactively arranging tests for contacts. Previously, we would have made contact and they would have isolated, etc. We're making appointments for those come forward for tests now.
And secondly, just on the private hospitals and private hospital capacity, there's a bit of a discrepancy between HSE figures of that occupancy at present since the deal came in and what's coming out from the hospitals themselves. So I'm just wondering, how is it measured? Is it measured by overnight stay? I know Anne had mentioned that some inpatient beds are being used multiple times for day cases. So I'm just wondering if you can tell me how those rates are.
Yeah, so just to be clear now, the inpatient beds aren't, the day beds are different, so we count them differently, both in public and private. So we have day beds that would not be staffed or available for inpatients. I think the occupancy we capture on the basis of reported activity, so no more than we capture our own, so it's based on bed occupancy over night times, so it's a nighttime period.
That you, Keenan? Okay, Adam.
Adam Higgins from the Irish Sun. Does the non-COVID care plan that's coming next week include the private healthcare capacity, and for how long?
Just on the overall framework that we're bringing out next week again, and I did state it's going to be an iterative plan. It's not just our framework, it's not just a point in time. It'll be over the coming weeks and months. It will leverage based on our capacity in our acute system, our community services, and our social care services. Currently, as we're working, and within the current agreement, it is in terms of what we know we have available for us. Obviously, the decision around private hospitals and the utilisation of private hospitals beyond June is a decision ultimately for government.
So you're not actively planning for the use of private hospitals past June?
No, we're planning based on the known capacity that we have right now, and we have that capacity to June and potentially on further July and August. We're planning based on what we have. But again, just to make the point very briefly, just on as we look at the non-COVID services, we do know it's a fact that even utilising new ways of working and encouraging people not to have to come to hospital settings, we do know that level of the services will be less efficient. Colin gave an example just in terms of waiting rooms and outpatient rooms at the minute. There'll be less people we can have congregated at points in time. So we have to look at the total capacity that we have to us.
And just finally, how do you feel the deal with private hospitals has worked? Has it been positive, and would you like to see it extended for the full range of the deal?
Yeah, just three things on it. Firstly, the procuring of the private hospital groups was absolutely the right thing to do at the time. When you look back at what was happening all across Europe and the expectation of a massive surge on our hospitals and the horrific scenes, frightening scenes that we're seeing all across Europe, it was absolutely the right thing to do at that point in time, and it was procured for a particular purpose. Second thing to say, and Colin has mentioned it very briefly, from the 27th of March, quite rightly, non-COVID services except urgent care was stepped down, and that remained so rightly until the 5th of May when it was encouraged to take it up. So then we have to look at what services can we utilise the private hospital groups in a very different way than it may have been procured for, and that's what we've been working through over the last couple of weeks. And finally, from my perspective, we do look forward to the coming weeks and months as we've seen the reduced capacity in our public health system. Although we still 800 beds available, it is significantly reducing and continuously reducing. We have to look forward and be very clear that we do need further capacity in the coming months to protect us against potential surge or another potential peak in the virus. So from our perspective, we will continuously need extra capacity.
Okay, we've done a full round. Sinead, Kesh, Gaelga, Quig, Dr. Henry.
Rashkadina to alternate reach just kan keshin har vidini borha fina figuri bejer go hula shoot fushin and fejel atirik kurshi siena version.
Well, an kid till she's a gawch sheer nish agus ag glacalish the figurin is Jenny is learning in iskol and virus corve much musa fubble agus is a weekas lahan dinny agus a clealish realka cor vaim ag dermi varta agus in racha another too much burger free fos na made na ragan and we na tea halterness agus na monarch fuel of fosta agus isaging I made an tolesta agi imagination virus agus imagine 300 years done a mage ni one o captain ko laga la agus isaging go mulen virus go tubben agus go gair dini is the har in dini ela musa fubble. So to man jigopper law la kela is kush a hash doing inish go will na mage no ragane ag dol nish nil rag be le chakten nu some wis and here alternation agus is my audition ach to man jigopper law la kela sn hudras sn here alterness so do is coming able to tralio costa hala har ko gastes feature agus hulu Kiana o an sha gor which ag salahar and could just know den tralio costa done chorus done arnoil tea halters agus na kish done tea halters piwajak so agus har rudbe ele ta cacti aginish ta tre na virus eros aginish ta ag done made o cacti cactin go hairage an dói a chunsisteach a riine éasta agus bí agus bí na ceachtaí sin ra siad chun lasa dúine seach.
In Keisela?
Paul Reid faoi fiúháin muna gapan tú go bhfuil COVID ort go a chóir dat dul le haid testal má fáin tún litir sin gúil tú de close contact.
Well, mar dúirt mé ceanna tá tré an díras agus tré an galar ag dul méid ó ceachtain ceachtain agus is a gínis ag tús an galar seo ag áhah siar i deirí bharta hín focail méid nó hiigmuid nó ceapmuid go raibh na háirí go a bíad na háirí an ní is tátaí maidir leis an galar seo. Tá is a gínis go mín goil sé chumas a duine an vírs a scapú solar nélann si don vírus so solar míon na háirí a mé agus na cóirthaí mé sin an casacht agus an fívras tá ahan seans an tá builán go mé daoine ag scapú an vírus go bhéir sin tá sé tharbheith tátas go mé ahan duine ag dul muín an testáil se más rudé go ró siad go rá nasc aigen ó eici le daoine a ró an galar acha.
Okay, so Nicole, has Berla no Askelga?
Osberla, away. So just in relation to the 2-metre physical distancing rule, there was a lot of debate during the week whether it would be maintained or not. I know, Paul, yourself, you mentioned last week, the briefing, that if it was to go to 1 metre, it might make certain things in the health service a bit easier. Obviously, Tony Holohan recommended yesterday to Cabinet that it should be kept at 2 metres for the moment. I was just wondering, what did you think of that? Are you still standing by the fact that 1 metre would make things a bit easier? What was your response to what Tony Holohan's now recommended?
Yeah. Well, as I said last Sunday as well, we're guided by the public health advice, have been from the start of this, will be throughout it, specifically making the point 1 metre as we look at the non-COVID services restoration. We look at our emergency department rooms, we look at our outpatient rooms. We will have to plan based on 2 metre if that's the decision of government. And obviously the CMO has made has given a view, ultimately a decision for government. But I was making the point, 1 metre gives us more capacity in terms of bringing people in. But ultimately it's a public health guided decision, and we'll work to that.
Colin, do you want to come in there on that?
No, just exactly the same, that it's based on the notional length of a droplet transmission, and to remind everybody, it's a highly transmissible virus, it's droplet spread, and as we have discussed here and other places, the only cure are those measures which include keeping apart.
Okay. Are we done? I think we are. So thank you very much for coming. Our plan is we'll move from a Sunday to a Thursday or Friday briefing from here on in. I'm sure everybody will be happy with that. So hope you found it useful, and thank everybody at home for joining us this morning, and we'll see you at the next weekly briefing. Thank you.